Very good evening. My name is Dr. Kamal Kumar. I head the Medical Affairs Department of Ajanta Pharma Ltd. And on behalf of Ajanta Pharma, I welcome all of the respected experts and all of the delegates for edition 2 of Cardio Master Workshop. This is the fifth session today. Today's agenda is on interpretation and interesting cases on coronary angiography. Speaker for today's meeting would be Professor PK Goel. Moderators would be Professor Ajay Mahajan and Professor Milind Phadke. Among expert panelists, we have Professor BC Srinivas, Professor Sandeep Bansal, Professor S. Harikrishnan, and Professor Rishi Sethi. Along with, we have postgraduate students, Dr. Sriram from LTMC Mumbai, Dr. Sunil Mondal from GB Pant Delhi, Dr. Abhik Haldar from SCBMC Cuttack, Dr. Umesh Tripathi from SGPGI Lucknow, Dr. Sandeep Sharma, SMS Medical College, Jaipur, and Dr. Pratik Chopra from LTMC, Sion. So the Professor Ajay Mahajan is Professor and Head of Department of Cardiology, GS Medical College and KEM Hospital, Mumbai, and Professor Milind Phadke is Additional Professor at Department of Cardiology, LTMC and LTMG Hospital, Sion, Mumbai. Dr. PK Goel is Senior Consultant Cardiologist at Lucknow. Professor BC Srinivas is Head of Department at Jayadeva Institute of Cardiology at Bangalore. Professor Sandeep Bansal is Head of Department of Cardiology at Safdarjung Hospital, New Delhi. Professor S. Harikrishnan is associated with SCT IMST Trivandrum, and Professor Rishi Sethi is associated with KGMC Lucknow. With this, without taking much time, I would request Professor Milind Phadke to kindly kickstart the meeting, please, sir.
I'm speaking to Dr. Srinivas.
Hello.
Dr. Srinivas.
And welcome.
Sir, I am Srinivas from Ajanta Pharma, Senior General Manager.
Can I go ahead?
Okay. We have, you are as a panel, sir, today's webinar.
IT team, can you please mute?
You are a panel. Okay.
Okay. Good evening, everybody. And welcome to this fifth edition interpretation of various spotters that Ajanta has very kindly set up. And we've had very good responses to the first 4 programs. And the students, I think, are benefiting as a whole. And we are really grateful for the enthusiastic student response as well as participation. And we have a very elite panel today. Dr. PK Goel, sir, whom all of you know, he's going to present the cases, the presentation first on the basics of how to do coronary angiographies and then some interesting cases. And we have a very distinguished panel of senior professors and consultants from all over the country, whom Dr. Kamal has already introduced. So they need no further introduction from me. Coronary angiography and its interpretation is probably the most basic thing that a student in cardiology has to do once he goes into the cath lab. And without much ado, I will hand over to Dr. PK Goel, sir. And I'm sure we are going to have a very, very instructive and informative evening from now on. Thank you.
Yeah. So you want me to start, or there's something else?
Yes, please, sir.
Okay. So is Ajay Mahajan there?
Yeah, sir. Dr. Ajay Mahajan, sir, is just joining. He said he will.
Okay. Because I see Sandeep Bansal and lots of senior faces, so that's not an issue. That's fine. Okay. So actually, how I took the topic was this whole session. This is a teaching session. Now, teaching session can be done in 2 ways. One is you ask questions from the students and they answer. The other is if there is something that you can tell them on the background as to how to do certain things the right way, then maybe that can also be a good teaching for the students. So this thing will be largely, the concept of understanding an angiographic, understanding the coronary anatomy, and interpreting coronary angiograms, which forms the basis for any intervention, any coronary intervention or any intervention today. So this, I will talk of some basics, which may be a little different from run of the mill. These are some strong concepts that I believe in my 35 years of experience as a faculty and teacher. So I'll go through that. And then at the end, I will have a few angiograms, which based on this, people can try to interpret this. That's how I will go. Okay, is that all right? Whoever, okay. So why is this? Is these slides not, okay. So friends, performing a good coronary angiogram and its right interpretation forms the basis of a good coronary intervention. Understand that. And everyone, I think 90% of your job is coronary intervention once you pass the DM. This is an art which often is taken for granted. That is the unfortunate part. And not uncommonly is lacking in a good number of interventionists. Leave the students, even one has to understand what I am saying, the gravity of the thing. Now, a few basic angiographic principles I will tell you. First is know the anatomy or outlines of the heart chamber, because you understand the coronaries envelop the heart in 3 dimensions, but are visualized in a 2D on a flat plate on that screen that you see the coronaries, right? But so you always, and the coronaries run along these specific anatomical parts of the heart. So if you understand the heart chambers behind it, you will interpret things better, especially because it's just not a question of picking up a stenosis and saying how much is the stenosis. There are different anatomies, there are variable anatomies, anomalies. So everything has to be understood. So visualize the heart behind the coronaries in a coronary angiogram. When there are some odd things, if you imagine the heart behind it, you will always come to the right conclusion. Get the concept of distance. On a radiographic picture, 2 points lying close together in a single view could be miles apart in another. Understand this. Supposing there is something right in the front of the heart and something right at the back of the heart, at the same level, you will see it almost as a single dot or very close 2 dots. But if you see from the opposite side, from the lateral side, 90 degrees apart, you will see one right in front and the other on the other side. So these are things which we often make mistakes. So these concepts have to be understood. Always, that is why I always say and believe that you must see in 2 orthogonal views. And sometimes if I show you a picture only in a single view and I ask you a question, I would think that the person who's asking the question is not truly doing the right thing. Because things have to be seen always. You have to give 2 views. Without 2 views, you're not expected to interpret. So that's why whenever we do an angiogram, we take a RAO type view and a LAO type view. It's a type. So as long as you are about 80 degrees or 70 degrees apart in the 2 views, it's fine. Understand the concept of parallax. Now, what is this parallax? 2 vessels on the same surface, if they're close together, they will move together. They'll move in parallel. But if they are on the opposite sides, then the heart, as you understand, the heart contracts. So if you are seeing in this plane and the heart is, they will move in opposite directions, right? So if they are, although anatomically looking very close together, but if they are moving crisscross, that means they are on 2 sides of the heart. So one may be in front, other the back, or one on the right and the other on the left. So I'll show you some examples for that, and then you will understand that. Now, this is just to show you a conceptual, this is where the heart is placed in the body. And so we have the right and the left, and then we have the cranial and the caudal. Okay. Now, so image intensifier actually is the eye. We call it the eye. It is the eye. So just like your own eye, so you have to understand that the image is being formed in the eye, and the X-ray tube is generating the X-rays, and it is falling on the image intensifier. And an image intensifier is the eye, is your retina. So So that is how, if you understand, then you will know how the cranial and the caudal goes, because these are concepts which one has to understand. I know I'm talking something very basic. Someone may think it is too simple and it's not necessary. Well, that's fine, but I think these things give you some bearing. Now, this is, I have shown the heart there with the arteries. So now if you see from the right or the left, so, you can get an idea where this artery will look in an RAO and a cranial RAO and a cranial LAO. So this is the RAO view. So you will see the heart, the AV groove will be flat, and you will see the length of the heart. Okay. In the LAO view, it will be just the opposite. The AV ring will be open, and you will see the, so if the AV ring is open, so you see the circumflex running on the right, on the left, and the RCA running on the right. So these are things which, now this is just a small line diagram which will trying to explain, this is of the ventricles, but the arteries are running on these ventricles, on these interventricular grooves, posterior grooves, and the AV rings. So understand that in a iliocranial view, so this is the mitral ring, this is the tricuspid ring. So the vessel LAD comes out, it runs along here, along the interventricular groove, and then comes down, and the circumflex goes around the mitral ring. So it goes like that, and it is flattish. OMs will hang down, as against a straight LAO view. Here the circumflex will be more open, and the OMs will be foreshortened. So if you want to see the lesions in the circumflex, then a straight LAO view is better. And if you want to see lesions on the OMs, then probably iliocranial is better. I hope you will understand what I am saying. And now this is a RAO type view. Both the AV rings are one over the other, but the length of the heart is seen. Atrium are on one side, ventricle is on the other side. So with this, you can always, so you can get an idea. So the OMs will get long in all RAO type views. So RAO caudal, straight RAO, you see lesions, or even RAO cranial, you see lesions in the OMs better, but the proximal parts of these vessels get foreshortened. So that's how you choose the views. Very few basic vessel coursing rules, RAO versus LAO projections. Yeah, so this I have summarized. Now, surface anatomy of the interventricular groove runs where the LAD runs. So if you know that, then anteriorly on the front, you will have, it divides the heart on the RV side 2/3 and the LV side 1/3, something like that. So this is this. Now, if it is LAD contour forming vessel in AP view. Now, I don't know if any student can answer. Is LAD a contour forming vessel in a AP view? Can some student tell me of the heart?
No, sir. So
If I do a AP view, and I am looking at the LAD, will it be the contour forming? Means wherever the heart contour is there, will LAD run along the heart contour?
No, sir. The diagonals will form the contour, and as we move more RAO, we'll have.
Who's answering this? Who's
sir,
answering?
Umesh.
Umesh, he was my student. Okay. All right, that's correct. So it will not be the contour. It will never form the contour, right? But if you make it RAO, as you go more and more RAO, the LAD starts forming the contour. Okay, it gets more and more on the outside. Now, surface anatomy of the AV groove, I showed that. You see, it is in the RAO view, it is the two valves are one over the other. Atria and ventricles are separated in RAO, but not in LAO. There'll always be overlap. So, PDA, PLVs, well, they overlap usually. But there is one important thing which is, if you can remember, which I will tell you, the PDA, when the heart contracts, the tip of the vessel whose tip moves upward will be PDA, and the one who stays back will be PLV. Okay, sorry. The one which stays back is the PDA, and the one which moves up is the PLV. And why it is so? Because the PDA is bound by the interventricular. It is in the interventricular groove, and the PLV is on the lateral surface of the heart. It's on the posterolateral. So as the heart contracts, that goes up, but the PDA area stays straight till the tip. So these are small things. If you can understand and remember, then it will help. Angiographic technique. Now this is in every cine run, always have an initial dry fluoroscopic part included. Now, why do you want that? I have seen several people, the moment the injection starts, moment I do the fluoro, they've already shot the injection. You miss very important findings. What you miss? You miss the calcium. Calcium can only be seen without contrast. And if there is a hanging contrast from the previous injection, either because of a dissection or because of a thrombus or some other problem, you will see that hanging contrast before the injection starts. So always have a dry run first and then have the injection and follow the contrast as the contrast slows down, and keep interpreting as you are doing the angiogram. So that is very important. Contrast flow rate should be commensurate with the normal flows in the chamber or the vessel concerned, because you have to transiently opacify the whole artery with contrast without any blood. Several times you see angiograms where the contrast is not enough. There is layering. Why? Layering is because he has not injected fast enough to replace the whole blood. So the non-opaque blood is also coming and the contrast is flowing at a slow rate. So these are some technical issues which make interpreting angiograms very difficult. And what I am saying, I have seen this in my career. I'm not just creating out of nowhere. There are tons of angiograms that come. They just know that because angiograms are being done by several people all over the place. They just know that there's a catheter that has to go. The catheter is pre-shaped. It will hook the artery and just shoot and come out. That's all. Now, how much to shoot? Concepts have to be understood. You need to somehow fill the whole thing, as I told you. And these are the volumes that usually they take. I think people know that from the books, and always follow the diet. So I think this is important. Now, otherwise, if it is some other cath or something, wherever you enter, take pressure, take saturation, and think whether angiogram is needed here. This is in odd anatomies and this will not stand for coronary, but otherwise. I think we will skip on this. I'll skip on this. You want coronary, so. This is a picture which I want to show you because LV angiogram is quite important. We always do a LV angiogram because, actually I tell you LV angiogram, LV is to the heart as brain is to the human body. Now, heart is one, brain is one. Now, without brain, the human body is of no use, right? Even if the heart is working. Similarly, the coronaries are of no use if the ventricles are not contracting. So we have to know very well how the ventricles are. And the echo information is there, but echo information is a second-hand information. The same echo today you do and someone says it is 30%, tomorrow he says it's 40%, or it's 35 and it's 45. Makes a big difference. So I strongly believe in doing an LV angiogram. When you've injected so much, 20 ml for LV angio will not make much difference. And it really tells you how the ventricles are. And just a small tip that I always say, you see this angiogram when the diastole occurs as the non-opaque blood enters, you will always have some contrast layered here, which is in the atrioventricular septum. And when there is a AV canal defect, this is that hanging contrast along the atrioventricular septum, which is just below the aortic valve, just below this aortic sinus, non-coronary sinus. So here you see a straight line, and here this is missing. So that is what happens with the AV canal defect. I will show that to you in still frames. In systole, this is normal. This is diastole normal. So you have non-opaque blood going in, but still there is a line here, right? This is the atrioventricular septum. And this, when there is a AV canal defect, this is in systole, and in diastole, as it fills and this line is gone. So always look into this line And so that is one important thing. Okay. Often committed mistakes is a poorly performed angiogram. If the angiogram is not well performed, you ask me to interpret it, how can I interpret it? I cannot interpret. Because unless you show me the picture, show me the arteries opacified. If they're not opacified well, you can't interpret. Now, injection during partially hooked coronary artery ostia, this is where you get contrast layering and all, and you can't interpret things as well. Arteries are either showing layering of contrast or remain underfilled altogether, and you keep diagnosing them as stenosis, which are not existing. Inadequate number of shoots or views, as I showed you in the initial pictures, the heart is a three-dimensional structure, so and the arteries are going round and round around it. So every part of the artery probably is profiled in a specific set of view. We know all that, everyone knows that. But the thing is, you have to do those views. You can't just do 4 RAO type views and nothing on the LAO side. I have seen angiograms, RAO caudal, RAO cranial, RAO AP, something, and then there's not a single LAO. Well, LAO gives you more radiation, so I must not do LAO. Then don't do angiogram if you are so scared of radiation. Blocked contralateral vessels are not shown in the field of view at all. Now, if the contralateral vessel is blocked, the only way to fill it is from the opposite vessel. If the LAD is blocked, you will only see it through the right coronary. So when you are doing the right coronary injection, if you are not seeing the area where the LAD has to run, then you will never be able to see it. So you have to ensure that your angiogram covers that area of the LAD where it is expected to come. So that is an important thing. Injection and viewing not lasting long enough as to give time for the contralateral vessel to fill. If you just give a small shoot and stop it, because contralateral filling will take some time, it will go through the collateral, slowly it will go and then it will fill. And if you don't see the distal vessel, then neither can you do angioplasty on that. And even for the surgeon, it is very bad, because if the area is viable, even if the artery is 100% blocked, you will always see the distal vessel. I can assure you of that. So these are things one has to remember. And then invariably you remain blind on the LV side. I talked about that, the importance of the LV. Okay. So LV is to coronaries as brain is to human body. Now, the other thing that I wanted to tell you is that angiogram is a dynamic picture and needs to be understood as a collection of frames in one shoot. You know, it runs at 12.5 frames per second, 10 frames per second, 15 frames per second. So there are in 1 second 12.5 pictures there. So that is it. So you can't sort of interpret one shoot as one. So if that one shoot runs to 3 seconds, it has about 36 frames. And if there are 8 shoots, then 36 frames into 8 makes it about 300 frames. So your brain computer has to analyze those 300 frames, because every frame the pictures will change. So you have to at least conceptually, it's not that you're going to sit and analyze 300, but conceptually your brain has to understand that I am seeing through that. That's what you need to interpret, and not as a single picture. Then you will not miss anything. The other thing is you analyze this through inching. Just like we know the murmurs, we understand very well. If there is a murmur at the apex and the base, you inch your stethoscope. You know, you go inch by inch and try to see, is it the same murmur going up or there is a new one that is coming up. Similarly, when you fill the coronaries, you see it inching, means you see it millimeter by millimeter. Okay, I have seen the first 2 millimeters. Now I have seen the next 2 millimeters, next 2 millimeters, next 2 millimeters. And that way you analyze the entire vessel for any lacuna, anything that you are wanting to interpret. If you just see it as a single shot picture, you may sometimes, because things are happening very microscopic. There is a very tiny clot, or there is a very tiny area where the vessel is like what we call as a napkin ring stenosis, very tiny area which is totally narrow. But on the cursory view, everything looks good because you have not analyzed that particular millimeter. So your brain has to understand that, and you have to do accordingly. So I think this I have talked about. Okay, I'm sorry, there's some duplication. So steps in coronary interpretation. First is you have to identify the anatomy. What is the anatomy? Identify all the vessels in the patient. There are lots of variations in the branching patterns. So those variations, whatever it is, that has to be seen. And there could be variations in course. There could be anomalous vessels running through odd courses. So that has to be seen. And the myocardial value, or the I don't force you for myocardial value, but the importance of each vessel or independently diseased segment, how big it is from the myocardial point of view, from the area the heart it is supplying, has to be understood. Then the stenosis, because your interpretations and your decisions will, supposing there is a 100% occluded vessel, but it is so small, supplying such a small area, you can just forget about it. So it is not that you start counting a tiny tip of half of OM 100% and one PLV of 100% and one diagonal of 100% as severe triple vessel disease. So it will not have the same inference as you otherwise describe triple vessel disease, which could be a proximal LAD and a proximal circumflex and a proximal RC. So importance of the myocardial value of the vessels is important. Stenosis analysis, and then the final recommendation. So what is the more important information? If it is a surgical case, if the patient is to go for surgery, then what you need is how many vessels, how many branches really have important stenosis and which are large enough to get a graft. What is the quality of the distal vessels of these? And the number and types of stenosis is not as crucial. You say 70, then 80, then 50, then 60, and 40. Not, it is irrelevant. He's going to put a graft onto the distal vessel. But unfortunately, there's no reporting system, as you will realize, which really talks of the distal vessel quality as to what is the distal vessel. We keep counting. Now, those 30, 40, 80, 70 is very important for a patient who has to undergo angioplasty, right? There, because every lesion has to be handled, which is in the supply line. But distal vessel is equally important here because you can't sort of perfuse the vessel unless the distal vessel is good. But the fact remains that these multiple narrow, so as long as you say it is a severe disease, long segment, diffuse, or whatever, by some adjective, it's fine. So exact location of each stenosis is very important if angioplasty is to go there. But for surgery, it may not be as important as long as you understand how the distal vessel is. So that's that. And of course, LV is important. Now, pitfalls in reporting, each individual coronary anatomy is different. Pre-drawn diagrams that we sometimes follow cannot accommodate for this difference. Freehand diagrams do not have reproducibility and teachability because you can get skewed in one direction. You know, if you just start drawing, you will draw freehand. So, and most reporting systems have not laid importance to the myocardial value of these vessels, but this is very important. So, you know, as a concept, what I am trying to tell you today is, I think it is less for the exam. I don't know whether if the, whoever is the moderator, you can ask me to modify if you require. I don't know, Ajay Mahajan is there and Sandeep is there. You know, because I am going in a particular direction. I will show some examples also at the end and whatever. But if you feel, because this is, I thought for the students, it may be helpful. I don't know how you feel about it.
Absolutely, sir.
You know, because it's more important to understand how to do things and what to do rather than just asking you a question and then it's not an exam that we are conducting.
This is exactly the way we have been taught, sir. So please go ahead.
Okay. So they go more by, now the other thing is they go more by the name of the vessel. And now they say a ramus is blocked. Yeah. Now the ramus could be as big that it supplies the entire circumflex territory and the diagonal territory. And there could be a ramus that is hardly a thing which is of any value. So I would, how I work, I take the vessel as per its anatomical size. Whether you say a OM type vessel or a ramus type, it's okay, no problem. I am not that guy who in the exam will say, oh, this is not OM, this is Ramus. No, forget about it. Whatever it, as long as I understand this is the vessel, it's in this part of the heart, and that's how it is supplying. So ideal interpretive requirements are identify all independent stems with significant lesions rather than trying to count them as 1, 2, and 3 vessel disease. Okay. Branching patterns or courses and sizes of each stem is to be known, especially if it's the case is for PCI, because you have to take care of these branches and different courses and everything in PCI. Myocardial value is important and it has to be understood at least, and the stenosis analysis has to be done, and then you can calculate a score. Well, syntax is one score. You can do that. Well, there could be something else also, and then you make a final recommendation. Well, incidentally, I have made a new score for my, but it's not been sort of put to the test, so I'm not quoting it here, but I have made a new score which takes care of all these things that I'm talking about, the problems in coronary interpretation and myocardial valve. Why I made this talk, this is based on a 77 paper from 1977 where I was trained. This is the, I think, the only published way of reporting angiograms, which I have been doing for years together. Rest all it is the ACC American College system with some pre-drawn diagrams which people complete. But this is a freehand diagram, and then I wrote on this how to use, because that was 1977 when interventions were not there. Then in 1998 or something, I wrote in the Indian Heart Journal just trying to relook at the reporting of coronary angiograms in the interventional era. So I tried to modify a few things there, and that's it. So just to make you understand, and I'll not go much into details of it. So this is basically the heart. You have the septum here, believe it like that. This is the septum. This is the anterior part of the septum, interventricular septum. This is the posterior part of the interventricular. A is the apex of the heart. So imagine this whole circle as a cone. You know, it's like a tent. The A is being picked up slightly higher, but this is on a flat chart, so it looks on the same plane. So it is like a cone. So apex is here and the base is here. Base is the two circles. So this is the left ventricular. There's one left ventricular circle where the circumflex will run. And this is the right ventricular circle where the right coronary will run. And the LAD will run in the anterior interventricular groove. The PDA will run in the posterior interventricular groove. And the vessels will come out like that, you see. So depending on how big the vessel is, you can draw it and you can make it or whatever. So that's fine. But it's not that anyone is telling you to do that. But this I'm showing only to make you understand that the concepts. And then you, depending on wherever the branches are coming, you can draw exactly, and then you can do the crosses and say there's a stenosis just before the septal, and then there's another one or whatever, and then there's another septal close together or later or whatever, and then it's blocked here and the distal is plugged. Okay, and then you insert the stenosis. So something like that can be done. This was what we used to do. Incidentally, I am still doing it in my new assignment place also. I don't, there are fallacies of the syntax which I pointed out in a paper, and this is also very much related to what I talk about. You see, you talking of RCA versus LCX dominance, this issue is not completely addressed. Imagine a RCA, dominant RCA. What is dominant RCA? PDA. So PDA is from RCA, but there's only a PDA, nothing else. Rest everything is from circumflex. So this circumflex is more important than RCA, which gives a PDA, PLV all the way into the OM territory. So, you know, something like that. So, but the value given by syntax is only one, whether it is this RCA or RCA as superdominant. So things like that. LAD could be long or short. This is not addressed there. Myocardial value of the vessel. They keep counting vessels, OM. So someone may think I will put this 1, 2, 3, 4 OMs. Another man thinks I'll put 3 OMs. Someone else thinks I'll put 2 OMs because they're tiny twigs all the way, and then counting them only by 1.5 mm, that's also not very right. Sometimes depends on the total size. Sometimes you won't even find a LED which is 1.5 if you start measuring. So you can't say that LED is nothing. LED is always LED. So things like that are there. So we wrote it up. I wrote it up there and then made some improvements, whatever. Now this is an important part. This is something which I think you can note it down or remember or mug it up or whatever you want to do, but this is gospel truth. Mark my word, this is gospel truth. In a aleocranial view, you see, these are the views that you will do and what will you look for, because this tells you it takes only those parts which are not foreshortened in that view. In an aleocranial view, you will see the left main ostium beautifully, but mark you not the division. Division will be here, the LED and circumflex will overlap one over the other. But the ostium will be best seen, so that's why I always advocate a aleocranial view as the first view. Okay, and the angle is about 50-20, left main ostium, and then you see the LED diagonal division in a beautifully, and then you see the distal part of the circumflex, not the proximal. Cranial views, proximal will be gone. Distal circumflex, distal OMs, you will see very well, and you'll see distal RC. In a RAO straight, you will see the left main and the LED circumflex, an overview you will get. And then when you make a RAO caudal, the caudal has to be just about 15, not too much. Then otherwise you lose the benefits of caudal. You will see the left main bifurcation beautifully, but not the ostium. So if you want to see the ostium, see it in aleocranial. AP caudal again shows the left main bifurcation and the proximal LED and circumflex. Straight aleo, best view for circumflex. Mark my word, best view for. And I can assure you, even in the experts who are sitting, some of them may not be doing. They might be doing the entire circumflex angioplasty now. You know, RAO view foreshortens the circumflex. The circumflex part which runs in the AV groove gets foreshortened because you see that same length which in a LAO comes as a big C all the way. It comes in a big C like that. In RAO, it just as a part of the AV groove, it's foreshortened. So if there is a lesion which is somewhere within a short distance, you may miss it. So circumflex LAO 60 is the best. Lateral and 90 degrees lateral 10 cranial gets you the mid and distal LED beautifully. And RAO cranial gets you the entire length of LED. We always do that. I think that's pretty usual. And it shows you, it gets you the distal OMs. And then the usual inferiorly going LED, we do a AP cranial. And if it is a superiorly going LED, then you do a LAO caudal. The same, like everyone is a fan of spider view, but this spider view will only work well if the LED is superiorly going in or a horizontal heart. But if it is a vertical type of a heart, you know, like a heart hanging down, COPD patients or emphysema or whatever, or otherwise also a thin chest person, it's going down, LAO caudal will not show anything. By the time you get all that caudal, that inferior tilt becomes horizontal. That's all it becomes and nothing. So these are things to remember. Coronary views for RCA, I think these are standard. Everyone knows that. I'm not talk much on that. This is just showing that picture. And then to make it coaxial, sometimes rotation is required, you know, clockwise rotation. So it's not just a question of hooking the RCA. You have to rotate it. Now you see this in a LAO view, you see this is hooked. But the same picture in the RAO, the catheter is pointing anterior. So it is not coaxial. You rotate it more and then it gets coaxial, but then it will get deeper also. So this trick that I wanted to talk about. Okay. And always when you rotate catheters, you wait for the response to happen, because if you start rotating, and then you will see the catheter reaches the RC and then jumps out. Because the torque is too much. So you give a torque, wait for the response to occur at the tip, and then do the second torque. Okay. Graft angiography, a few things I just wanted to say: always do the native vessels first. Understand the paradox of the amount of filling through the native injection. More you see in the native injection, that means, again, a question. If I see a lot of filling in the native injection, what is your interpretation in a patient post bypass? I do the first shot left. Oh, I can see LAD with disease. I can see circumflex. Versus then another patient, I do the same thing. I inject and I only see a stump of left main. I don't see anything. Who is a better patient? Who is a better patient? Can one of the residents answer?
So the one
someone else. I don't want Umesh Tripathi to answer all the time. Someone else, please. Because Umesh Tripathi is my student. He knows everything what I'm saying.
Dr. Sriram, can you attempt?
Anyone?
Dr. Sriram? Dr. Pratik? Anybody else?
It's not so difficult, or no one wants to attempt it. You see, if I see a lot of contrast filling, a lot of vessels filling, that means the grafts are all gone. It's like a native patient. That means the grafts are all blocked. And if I don't see anything, that means the heart is getting flow through the grafts. So you should be happy that you are not seeing anything. That means the grafts are patent. Because finally, as I told you, if a vessel is blocked, it will fill through collateral somewhere, something will happen. Unless the area is absolutely scarred, right? So this is the paradox. Now, in graft angiography, you don't need native injection, you just do RAO and LAO and that's enough. Why we do the cranial views, the tilted views, and this? We do all that to separate the different branches, to see each vessel without foreshortening. Now, once the grafts are already there, I am not interested in seeing the ostium of the LAD and the proximal LAD and mid LAD. As long as I want to see whether the distal LAD is flowing or not flowing, because it's already had a graft. So the proximal vessels are defunct. So just 2 injections are enough. All the cranially tilted views and everything is only to identify and separate the branches. So, and 90% SVG is hooked with JR, and hooking view importance. This is, I don't know how many people would know that. Right grafts always are best hooked in a shallow LAO view, and left grafts always in a shallow RAO view. This is because from where they are attached, because the right graft is always attached right and anterior, left graft is attached left and anterior onto the aorta. So they will always be profiled in those views and you will see them better. Lima, this is again a rule, if you can catch on it. Select the subclavian in LAO, you know, the arch opens in LAO, you select the thing in LAO. But the distal part of the vessel is foreshortened in LAO. So, because you want every length of it, every millimeter of it as it is moving back. So, pullback has to be in RAO. With RAO, it is not foreshortened. The same thing I have shown in pictures here. Actually, these are Peter Brand's pictures, which I have. So, you see, this is the standard 50-60 degree LAO. Neither the right graft will be profiled nor the left graft will be profiled. Now, as you make it shallow LAO, then you see beautifully the right graft is profiled. Okay. And if you make it shallow RAO, then all the left venous grafts are profiled. So this is and then the pullback, as I told you for that. Radials we do every day. Small tips in the technique: ensure a painless procedure. Intradermal wheel, because the pain fibers all come from the dermis. So always make an intradermal wheel, you know, with those small blebs that will come out, and that will give you the maximum anesthetic effect. And when you do that, you will have less pain, and the less the pain, there'll be less spasm. All the spasm, everything is because of the pain, and so that is the way to avoid it. Single wall puncture is better, and anticipate a problem and act rather than action taken once the problem already set in. Suspect, when you're doing an angiogram, suspect vasovagal at the first evidence of a fall in heart rate before any symptoms occur. So you see everything is going fine. The patient was having a heart rate of 78. Suddenly you see the screen that now it is 65. The vasovagal is going to come. Give him atropine right then, and the hypotension will not come by. Handling catheter damping, I think arteries have high pressure, so let things flow back. So don't suck on the arteries. You see, let the blood backflow. That is the best way not to produce a dissection and stuff. And action opposite to selective hooking if you want to undo. Like RCA got hooked with clockwise. So rather than pulling it back, if you pull it back, it will just jump out. Just do an anti-clock. It will come slightly back, and you will get it out of damp. Something like that. I think I'll have to make it a little faster now. 100% block, but as I told you, it will be always invariably be seen through collaterals, and if it is not seen, then the only way is that it's an anomalous vessel. If the LV is not scarred and you don't see the artery, then that means it is anomalous. It's arising from somewhere else. We'll talk about the anomalous anatomies, how to catch on them. More often than not, you miss the blocked or anomalous vessel because the primary key working at the back of the cardiologist's mind is the vessel by name and not the myocardial territory to be covered. Very important. So if you try to imagine that the entire heart has to get blood vessels, has to get the supply. So if you work on that, then you will realize, because sometimes there is anomalous circumflex, but you see a big ramus type vessel or something just coming down in that territory. But you don't realize that there is a part, and the RC is also very small. So there is an area which doesn't get any blood supply, because so you have to think from, if you think from that perspective, then you will not miss vessels. So look for a void in the myocardial territorial supply. And in fact, the diagram that I make helps me in doing that, because I see the RCA is very small. The circumflex gave only 1 OM, which was not as big. So what is happening to the other area? There has to be something that has to come. So that way you can get it. Keep a clear count of the number and assessment of the anatomical size of the branches supplying every area. And maybe the opposite side artery is covering for the missing vessel in question, but then it has to be truly of a compensatory in size. This anomalous vessels, how to interpret their course. This is something which I think will be useful. Then I can show you one anomalous course vessel also. Now, normally that is the left main, there's the left coronary artery. That's how it comes in the LAO view. As I told you, it will fall in the interventricular groove. That's how it will fall in the RAO view, right? Now, the anomalous vessel is, the left coronary has to come from the right. Now, from the right, there are 4 courses it can take. It can either go behind the aorta, as this one, or it can go in between the 2 arteries, or it can go in front of the pulmonary artery, or it can go through the septum. So there are 4 courses that it can follow. Now, how will these courses look? This is a very important paper. You can remember, this is an old paper, but do remember this is the best paper I can tell you for anomalous vessels to interpret, to understand how the courses can be. So now, when it is going, so as I told you, there are 4 courses. In front of the RVOT, septal, retroaortic, or interaortic. Now, if it is going in front of the RVOT, it has to, this is where imagining the heart behind the arteries works. It has to cross the pulmonary artery or the RV outflow. So it has to give that space. It has to move forward. Okay, so it will make a loop which is anterior and a loop which is cranial. The loop will be anterior and cranial. Okay, so in RAO it will look like this, in LAO it will look like this. If it is a septal course, then it is to go through the septum. So from where it starts from the right sinus, it will come down. So the loop will be caudal, but it has to still move forward. So it will be caudal and anterior. This is how it is. If it is a retroaortic course, that is the easiest to interpret, and that's the commonest that happens. It goes behind the aorta. So first it comes down, so it is caudal, and then it is posterior. It is going, because the aorta is the posterior most structure, so it is still behind it, so it's a posterior. So it is posterior caudal. And if it is an interarterial course between the two arteries, now the course is not anterior, but posterior, but cranial, because from where it is arising from the right coronary, it has to go slightly higher. It has to go slightly higher to reach the space between the aorta and the pulmonary artery. I hope you understand that. So this is how the four courses are there. So you have to only make out in a RAO and LAO view whether the initial part course is cranial or caudal, anterior or posterior, and you know what is the. We will skip on this right now. This is when sometimes you have congenital heart disease or no congenital heart diseases. You have a dextrocardia. You have a dextrocardia, and you have a mirror image branching. So whatever. Now, what happens to the coronaries, and how do you interpret these coronaries? When these coronaries are normal, if it is a part of congenital heart disease, there is no issue. You can always interpret them. But think of a situation, this patient of dextrocardia has atherosclerotic coronary artery disease and severe triple vessel disease with half the arteries blocked and 100% and blah, blah, blah. Now, you will find it difficult even in a normal patient to interpret the vessels. Now here it is dextrocardia, the vessels are all very oddly placed. So this is a technique, I think, very important. You must try to remember it. This I published in CCD in 2005, called the double inversion technique. I will show you the pictures of this. What is that double inversion? One inversion is whatever you want to see as LAO-cranial, you will see as RAO-cranial. Same, so if I want to see LAO-cranial 50, LAO-25 cranial, make it 50 RAO and the same 25 cranial. You will see the picture as a LAO-cranial would look, provided you, this is one inversion that you have done, and second is you do a right-left sweep on your system. The system has a right-left interchange, so you have to do that also. If you do these two together, then you will see it like normal. Now I will show it to you. Now this is from a dextrocardia patient that I had with severe coronary artery disease. Left coronary artery. This is the LAO-cranial view. A is standard LAO-cranial view. Can you make out that this is LAO-cranial? I doubt if anyone can, because in LAO-cranial, I expect the LAD to come in front and circumflex behind, and then whatever is happening. Now, this is the picture of the same view with double inversion. Looks like a standard LAO-cranial. Now, lower down is LCA RAO injection. Now, can you ever imagine this could be RAO and which vessel is blocked? At least I can't tell. But now when I see with double inversion, I know there's an artery running in front, which is LAD, as I expect in RAO. So LAD is not blocked, but probably the circumflex system is blocked, and I know how to interpret. Now, similarly, LCA, this is a straight LAO view, hardly looks a straight LAO, but with double inversion, yeah, it looks like a LAO. This is the LAD in front and the circumflex behind, and that's it. But there is a double inversion there. So that's how it is. So that's what I wanted to show. So this technique, if you remember, it will help you in dextrocardia patients. Okay. This is standard type ABC lesions. I don't think I'll go through that. The textbook tells you all about it. Lesion assessment prerequisites. Always interpret completely filled vessels. Avoid in contrast layered frames. No overlap or crossing of vessels. When vessels overlap, there's something called a MAC effect. This is a radiological effect. where the sharper image will dull the weaker image, make it even dull, and you will try imagining. And this is what happens, when you do bifurcation lesions and at the ostium of the side branch, you invariably feel that there is a stenosis. But then you do FFR and all, and then you say, oh, there is no stenosis. Well, if you have this eye of the MAC effect in the radiologist's eye, you don't need FFR. You will be able to interpret it correct. The right view and the right frame, eyes see what the brain knows. So if you know these things, then only you will be able to see them like that. Otherwise, you will not be able to see them. In a single, this I have talked. I'll skip that. I have talked. Eccentric stenosis, again, this is a textbook thing, so that's fine. I think I'll go to some examples. Let us skip this. Okay, a few examples. Okay, we have come to some examples. Importance of eleocranial view in left main ostial disease. I told you about that. Now I will show you. Now this is a RAO type view from a patient. Now, how's the left main ostium? Can you tell me? Seeing this view? These two views? Well, if no one is speaking, then I will speak. This looks pretty okay to me. I don't think there is anything in the left main. But the same patient, when I do eleocranial, see this. How beautifully in the eleocranial view I can get a cuspogram. I'm sure you know what a cuspogram is. You see the cusp and you see the vessel arising, because this proximal part of the vessel was all foreshortened, in the caudal views. And there is the stenosis, as the arrow shows you here. So this is what I was trying to say. Okay, so remember this. Now this one, OM. So you feel, well, at least what I felt, I said, it looks like a moderate disease in OM. Okay. What is this? This is a RAO type view. As long as you say it's RAO type view, I'm okay, no problem. This is some RAO and some caudal. Okay. So this is the OM looks okay, moderate disease. But when you see the LAO, now this was a very short segment. Now you see this. There is a severe stenosis here. This was a very short segment, and this is what I was trying to say, that in RAO, these parts will get foreshortened. So what will happen is that the proximal, because the lesion is so short, the proximal part of the lesion will overlap over the distal part and you will not see it. But the LAO view will show it. So that's why the LAO for certain. What is the significance of this LAD disease? Now, can someone interpret this? Can someone interpret this LAD disease? Anyone wants to interpret? Any one of the students? Can you see what it is like? Sorry, I'll run it. Yeah, it's running. How will you interpret this LAD? Is there someone responding or not responding? Your volume is very slow. I don't know.
Students to step up and answer. They have not been interacting.
Sorry?
I said some of the students to step up and answer the questions.
You see, how do you just say what you feel about the LAD? I will help you out. I will show you what.
Sir, can I speak, sir?
Yeah, please, Umesh, please.
Sir, this seems to be a moderate long segment disease in the proximal LADs.
Moderate long segment disease, isn't it?
Yes, sir.
Certainly, that's correct. It looks like a moderate long segment disease. But then the other thing that you must know is long segment diseases get significant. The same moderate disease, if it is in a short segment, is not significant. But if it is longer, then it gets significant. And these long moderate diseases, several times we leave them as moderate. Okay. But now This is the just a sec. I didn't get the FFR, is it? I think I missed the FFR. I did a FFR on this, and because it is long segment, so it was significant. The FFR in this was about 0.74, if I'm not okay. So the importance is that when lesions are longer, even moderate could be seen. That is one. Now, RCA CTO, you're filling through collaterals. Now, there are one CTO or two CTOs. See this picture, use my principles, and then answer that I told you today. You see, there is a right coronary injection. There's a right coronary injection, so there's a CTO here. The point is, then it's not filling beyond also. So are there one CTO or two CTOs? And how will you make that out? I have given you the right injection and the contralateral left injection, which is showing you the, now, if you, because these things help you in intervention. Don't, this is all the basis of intervention. This is telling you how I am able to do interventions. Now you see the contralateral filling. Now you see the contralateral filling. It goes up and then comes down also. That means when it goes up, it goes from the left coronary. But when it comes down, there is something that means it's coming down into the right coronary. That means there is some antegrade filling coming up. And in this first view, you don't see things flowing down, but there is a to and fro at the end. And why it is not flowing down? Because it is flowing up from the other side, because finally it will flow only one way. So which is telling me that there is a what do you call that, slush type of an area here, where there is flow from the top and from the bottom. So probably there is only one CTO, it is not two. And several people will write is at 100 here, 100 at the top and 100 below that, which is wrong. And that's why when you opened it, you see, when I opened the top one, I got flow all the way down. There might be some disease here, but it is not 100%. Okay, so these are things. I think this is this. We will move forward. I had something else. Contralateral injection, we talked enough. Okay. I'll just conclude what I talked, and then we will go to some more, a couple of examples, where there'll be questions, you can answer them. So what I wanted to conclude was, seeing or imagining the heart behind the coronaries forms the basis of understanding the coronary anatomy. Understanding the coronary anatomy forms the basis of performing a good angiogram. Performing a good angiogram forms the basis of correct interpretation, and correct interpretation gets to the basis of good intervention. Visualize each angiographic run as a collection of images and not as one snapshot picture, which forms the foundation for interpreting the flow patterns and stenosis severity. All this I showed you in these flow related pictures. And orthogonal viewing, that is in two planes about 90 degrees apart, forms a fundamental for knowing or understanding the reality as to what exactly is happening. And it is skills of a good angiographic performance and correct interpretation that finally will form the basis of a good and successful coronary intervention. I can assure you of that. All those who will believe in it will do well. If you don't believe in it, then you do what you want. Okay. And the best interventionist needs the cardiologist's mind and the radiologist's eye. Mark my word. Okay, thank you. So now, okay. So this is a picture which I got from one of the cases done by someone. Can you tell me how good or bad this stent placement is? What is happening here? Can someone, can anyone interpret this, please? By who's the moderator? Let the moderator ask one of the students to interpret something. Is someone there? I don't know. Everyone has gone to sleep.
Milind sir.
Kaun hai bhai?
Everybody is there, sir.
Let the panelists speak, yeah.
Milind sir.
Yes, yes. I was just waiting whether any of the students are attempting. Where are they? Nobody is responding apart from Dr. Tripathi.
Tripathi is there, Umesh.
Our panelists also.
Panelists are also sleeping. I think it was a good sleeping pill.
Harkishan sir.
I think, is there some problem with the videos of the students or something like that? Dr.
No, sir.
Sriram?
Dr. Umesh is there.
Because he could see everything.
I think they are on mute mode, so.
Sriram is not there.
Anyhow, this is interesting. Can anyone else? Because this relates to angiography, you know. This relates to the angiographic thing. That's why I brought it up. Actually, anything wrong in this injection? Anything scary about this injection? Well, I got shit scared seeing this. Now you see, this is a guided catheter. He's trying to do a left LAD angioplasty. There's a stent that is being inflated. But you have to see this whole circumflex system is hanging contrast. Why? Because you are doing it in areocranial view, the catheter is so deep, you are not able to interpret how deep this catheter is. In areocranial view, you miss. I told you in areocranial view, proximal circumflexes get missed. You can't interpret proximal circumflexes. Now what is happening is, in this view, he's gone beyond the division of the left main. He is centering his eye on the lesion here in the LAD, not realizing that he is damping the circumflex and the circumflex is occluded. That's why it's hanging. Okay. And this is the next shot. Patient goes into massage. All right.
So somebody from the audience, it is a die hold. So at least some people are attempting.
And this is the last shot during the cardiac arrest. Now you see this. Now you don't see the circumflex at all. Because these views, when you are doing such cases where left main is important, circumflex proximal is important, see them, do them in in areocaudal or epicaudal, where you will see the division of the two vessels. You would keep your guiding away from the division and then handle the whatever you handle. In this cranial view, you go deep and you don't know what's happening to the other side, and the patient gets in arrest. Okay. Now, interpret this LAD disease. I think it is similar to what again, I think what I'm trying to show is there is a occlusive type lesion proximally, but distally, there is another block. And how you can make that out is when you see the distal one, when you see the contralateral filling from the right, when you see the filling from the right, you see, although it was flowing antegradally, you do get, I don't know. you do get, I think the RAO view is not here. That would have shown it better. So the wire is also getting stuck beyond this occlusion. And that was again interpreted by the flow pattern. You get some LED filling here, which is again is getting stuck at one point. It is not going to and fro as it was going in the other one. So you know that there is another area that is here, somewhere here. There is a plus minus 100 lower down. These things sometimes show better on a real picture rather than on these AVIs. Okay. What is this? Okay. Now I don't know if anyone wants to. Now this is something related to the anomalous vessels. The loops that I was talking about. So now this is a cranial loop. You see there is a left vessel which is coming from the right, but it's taking a cranial loop, okay, and it is anterior. So this is going in front of the pulmonary artery, of the RV outflow. So that is what I want to show here. I think we can skip this. Okay, this someone should tell. What is it? Can someone tell me this? This is like an exam angiogram. Oops. Yeah, can someone interpret this, please? Umesh Tripathi ko bolo.
The circumflex arising from the right sinus.
Circumflex arising from the right sinus. What is the route it is taking?
So please run it once.
So we have given you two views.
What kind of a loop is the circumflex forming? How is it going? So I just said, na. Can you tell something on that?
Interarterials.
Sorry,
Interarterial.
This is whenever this is asked, what I have observed with students, 80% of the cases they will say interarterial. Now, you see, you have to understand, and this is what I showed you in that paper which I showed. Now, this is caudal, it is coming below, okay? It is coming below, and in the LAO view, in the RAO view, it is posterior. See, this is RAO view, that is the right coronary artery, but the front is here you have the sternum. So it is going back, so it is going posterior. So it is caudal and posterior. If the circumflex is arising from the right coronary, going caudal means niche and posterior behind. Where will it go? It will go behind the aorta. Imagine the aorta in this place. This is what I was talking about. Imagine the heart behind the coronaries. The problem is you will always want to see the coronaries independently. Now I will show you to just hold on and understand this. Now, if the right coronary is hooked by this catheter, that means the right sinus is here, the non-coronary is here, and the aorta is here. So imagine, and this is a LAO view, the first one. So imagine draw the aorta in your mind, in your brain computer. When you will draw the aorta, you will immediately see this vessel is going below the aorta. And here, if you will draw the aorta, so this is the RAO view. So the aorta is sitting here. So it is going posteriorly and it is going again beneath the aorta. Just imagine, because that is the aorta here, and you have the heart, the AV groove, and the ventricle will be like this in this triangle. So if you imagine the heart behind these coronaries, you will otherwise also make it. And this is a posterior retroaortic force. Okay. This is a retroaortic force. What is the problem? You see, there is the catheter is all gotten. I have no length of catheter and I have not reached the coronary ostium. Why is it happening? Why is that happened?
Bovine arch.
Yeah, that's correct. So it's a bovine arch. So everything is being taken up here because it's going all the way posteriorly and then trying to come. So the length is all lost here. Okay. All right. This is another picture. So what is happening here? Can someone tell me? We've done an aortogram, and this is the radial wire. Okay, it's gone into the aorta, but it's taken a very odd course behind and then come. So what is it? Is it, can you interpret? This is the LAO view and this is the RAO view. I will always show two views. I will never ask you a question in a single. So this is again a bovine type of arch or something. Catheter from the right radial is going all the way here. Looks like the same as it was in the previous one. Yo. You see, when you see pictures like this, and then an aortogram has been done, but now you see in this aortogram, you don't see anything filling here. This is going through a route which is not, the artery is here. Artery is here. In this track, there is no artery. You can see my cursor moving, no? Can you see my cursor moving? Huh? So there is no artery filling here. So that means either it is not going through an artery or it is going through the artery, but the artery in this injection is not being filled. You get it? And ऐसा तो होगा नहीं कि it is not going through the artery, most likely. So this is actually an anomalous right subclavian coming as the last branch of aorta, and I am injecting in the ascending aorta. By the time it reaches here and has to reach here, it becomes very dilute, so you don't see it filling. And then I think in the next one you will, there it is.
Dr. Goel, sir.
Yeah.
There are some questions in the chat box which some of the members of the audience are asking.
Okay. Okay. So I will. I think I am through with this. So this is the anomalous vessel actually. All right. This is another anomalous one. I don't know if someone wants to attempt that. Then we will. This was. This is a little difficult one. So, you know, again, there is a left coronary, which is left main, which is coming from the right, and it is taking a cranial and anterior loop. But then the issue is it's filling the LAD, but the circumflex, where is it? This patient had acute MI. This was a very interesting patient. He had acute MI, and the circumflex was not filling at all. Actually, we did an angioplasty on this. So going through that, you see the stump behind, that is where the circumflex will come. And then after that, now you see that. So this whole thing is left main, this long left main. This is after the angioplasty. Now you see, it's like giving the LAD in front, circumflex behind, and with the ramus type vessel, all that. And it's the cranial anterior loop. Okay, so where are the questions? Let's see the questions. Can someone, sorry, another meeting. Who's this Ajanta? The questions are here.
Yes, sir, in the chat box.
I have opened the chat box, I think. If you can read them, you can tell me. There's no problem.
Yeah. So
The chat box, I don't. This is the chat box. Okay. Dr. Arvind Jaiswal, Lucknow. Circumflex originating from the right sinus. This is some answer someone has given in the meeting. I don't know what are the questions here.
One person has asked, what is the definition of a superdominant RCA?
Superdominant RCA. Yeah. So sometimes what happens is that you see a RCA, the RCA is expected to give a PDA, then the PLVs cover the OM, the posterior left ventricular territory, which is adjacent to the posterior descending artery or the posterior interventricular groove. Then it can give branches onto the OM territory. The next territory adjacent is OM, and then further on is the diagonal, and finally you reach the anterior interventricular groove, PLD. So a superdominant RCA could cover the PLV, but those PLVs could also cover the adjacent OM territory, and a tiny twig goes even up. And the circumflex is left with only one single OM, which may supply the upper part of the OM territory. So it is a very big RCA. It's like a superdominant RCA. That's what it is. Okay. And you get these anatomies several times because coronary anatomy, no two patients is the same. That's why you can't have exact replica. So every patient has a different anatomy. Anything else? Who has asked anything else?
Dr. Rahul has asked, sir. Bilin, sir. What is the minimum vessel diameter vessel to put a graft on?
No, I didn't understand. I didn't get the voice is echoing.
Sir, the question from Dr. Rahul is, what is the minimum vessel diameter to put a graft on?
Well, any vessel which is more than 1.5, because if we account for vessels more than 1.5, then any vessel more than 1.5 should get a graft. As simple as that. Okay.
Okay, sir. Next question is, sir, whether coronary anatomy is more important to coronary physiology?
Coronary anatomy is more
important or coronary physiology? Which of the two is more important? That is the question asked by somebody.
Well, both have their own roles. Anatomy means anatomy. Well, you could have different anatomies, no problem. That's okay. Unless so coronary anatomy is something to be interpreted, and physiology. I don't think this really relates. Every vessel has its anatomy and has its physiology depending on what disease is there or whatever is happening in the vessel.
You have to integrate the information that you get from all sources.
Yeah.
Dr. Srinivas, sir, any comments so far, sir? Please, we would welcome your comments.
Sorry?
Dr. Srinivas, sir, he is on the panel.
Actually, I wanted some panelists to speak. I wonder, I don't know, I would love to have some comments from the panelists. Otherwise it becomes a unilateral one-way.
Sir, really nice presentation, sir. Sir, really nice presentation because with all your experience. So the points you highlighted, I think what you started from the beginning, saying that the angiogram is the heart of all interventional procedures is very, very important. And you stress the point that orthogonal views are always useful, and always you should take orthogonal views. That is the most important, because you will be seeing the lesion in only one plane. That may be the plane which is end face, so you may not see the lesion at all. So you have to always take the opposite. If you are taking an RO caudal, you should take an iliocranial, like that. So that is a very important point you stressed, and you should analyze the angio before completing the procedures and see whether you have missed some vessel, because some areas may be void of contrast, some part of the heart. That may be either a blocked vessel or it could be an anomalous vessel coming from somewhere. So these are all very important points you stress. Another thing which I wanted to tell is that when you are have a blocked LAD and you are not seeing it and the patient is for surgery or planning an angioplasty, you have to do a conus injection. Sometimes conus injection can give collaterals to that LAD. So that is sometimes very important.
Yeah, so the vessel will always fill. The point is the vessel will always fill. If you are not seeing it, it is your problem. It is your mistake. You are not hooked the feeder artery. So you have to know which all feeder arteries could be there. Conus could be separately arising. This will happen. The RCA is there, but the conus is separately arising and the conus is giving the collaterals. And you've hooked the RCA and you don't see collaterals because you cannot send the patient to surgery or angioplasty unless you see the distal vessel. Just saying that it is 100% doesn't mean it's over. The distal vessel will always be seen, unless it is a scar. And for scar, you know, this clinical setting will be there for the scar.
Yeah, and always in case you are not able to hook a graft, you take a aortic root angiogram to make sure that you are not missing any grafts. So
Yeah,
that also that should be done.
Correct. That's
So could you give them tips about Lima graft cannulation? Sometimes students,
Yeah, I think I explained that Lima graft pretty well. You have to hook through a JR catheter in LAO, and then the turbo wire goes forward, and then you move the catheter forward. Earlier, I used to change to Lima catheter, but now I think the RCA catheter, I've been doing it. You don't really have to change. But when you withdraw it back, then withdraw it back in RAO. Because as you see, if the, say, an item has a length of 4 centimeters, but if you see it only 2 centimeters, that is what is foreshortening, then your 1 millimeter move will in reality move it 2 millimeters. So you will miss, you will jump through parts. That's what the foreshortening does the problem. So in LAO, the subclavian is foreshortened. So you then make it RAO and you pull back in RAO. RAO opens up the entire subclavian. So you will move millimeter and millimeter and you will be able to hook it. You will see
LMCA cannulation sometimes to get into the subclavian, you may have difficulty with the Lima catheter. So what you can do is you can go with the RCA catheter, which you anyway you are using for the cooking the native
that's
RCA.
what I
You
said.
go to the subclavian and then you can exchange it with an exchange wire with the Lima in case you are not able to cannulate. That is one thing which you can do.
Also, sir, would you enlighten the students on the choice of catheters for cannulating some of these anomalous arteries originating from the opposite sinuses?
I think usually they get hooked by like opposite sinus means from the right sinus, if artery is coming anomalous, it will hook either by the JR or one of the amplards, AL1 or AR2 or something like that. And on the left side there's an anomalous vessel. I think again amplards is one choice that I take, and otherwise out of plane left catheter, you know, like
a smaller loop JL or an EBU sometimes maybe.
Out of plane left is well, we used to do it sometimes earlier, but now we don't do much. You know, like it's a Judkins catheter. In plane Judkins means it will go like that and it will be in plane perpendicular wherever the curve. Out of plane means it is coming down like this in one plane, but it is, you have tilted it like that.
Yes.
So because the right, when it comes from the left sinus, it comes very close to the left ostium.
Yes.
So either the left catheter will hook it or something out of plane. So you can make it out of plane. For that, you need to slightly heat the catheter and then turn it in that direction and then immediately cool it. So, you know, you can do that. But usually we are able to manage with amplards and stuff. I think so.
Yeah, see, another thing is that anomalous separate origin of LMCA, LAD and circumflex. That is one common anomaly, which is the most common anomaly actually.
LAD and circumflex. Yes, yes. So what do you?
In case, you are not able, you are hooking the LAD, the catheter is always going to LAD, then you can change to a larger curve that will push it to the circumflex. So if you are taking a 3, you are getting only
and
the
in a situation like this, always do angiograms with one selective into the LAD and look for the LAD views, and one selective into the circumflex and look for the circumflex views.
Yeah.
Otherwise, you will neither be able to interpret the LAD nor the circumflex.
Yeah, you say 0.5 more for the circumflex.
Yes, correct. That is
always
absolutely correct. That is absolutely correct. So a shorter curve will go into the LAD and a bigger curve will go into the circumflex.
And another point you stress is very, very important. I think when you start the injection, now you wait for 2-3 seconds to, the two things will happen. You can see the SRS and you can see the calcium, you can see the previous stain, etc. In addition to that, the image will get stabilized. So the machine will stabilize the image, and the clarity will be much more after if you inject after a second. That is very, very important.
Right. And the third thing, which I didn't say probably now, it's just coming out, it's out of my mind, is when you do that, you see the contrast flowing from the guiding catheter to its mouth into the coronary. So if you are injecting something inadvertently, you know it. It is not like that injection that I showed you where the contrast is already hanging in the circumflex and you are sitting in the LAD with the stent inside. You get what I mean? So you will see how the contrast is coming down into the tip of the catheter and getting into the LAD, into the vessel. So if there is anything wrong coming in there, a clot is there or a blood, something filling defect or some air is there, you will immediately stop. And when you see the contrast, as I told you, one more thing, follow the dye. So when you see it flow and then you follow the dye, your interpretation of the angiogram is far better than seeing a still picture or seeing a picture post facto. Yeah.
Another important point which sir emphasized even during his talk was that we often don't look at the length of the vessel when we assess its significance in terms of myocardial perfusion. So there is enough data now to show that the length of the vessel is directly proportional to the amount of myocardial mass perfused. So it's not just the diameter, we must also look at the length of the vessel to understand how important a branch it is. So that also should be taken into consideration.
Certainly.
And we should give the surgeon the maximum information, because you see there is a triple vessel disease. Don't just finish by 2 angiograms and leave, because we have to tell them which are the vessels which are to be grafted, where is a good graftable area. All those things we have to give it to the surgeon. Now what we see is on a triple vessel disease, 1 injection, 2 injections for LAD, 1 injection in RCA. For injection, that is what is seen. I think we should give more information to the surgeon, whether there is a good graftable area. All these counts actually. When you are seeing a blocked LAD, so you have to do, as Sarah rightly pointed out, you have to wait for the levo phase or the late phase, not the levo phase, the late phase of the angiogram to fill the distal part of the LAD, etc. And especially in RIO view, that is very good view, to where you see the collateral filling the LAD. And if the collateral is not filling the LAD, that means that the viability of that area is doubtful. So these are things you should consider. So you should take time to do an angiogram. I think it will take 2 or 3 minutes more, but that will make a lot of difference to the management of the patient.
Absolutely.
Sir,
Dr. Ajay Mahajan, sir, please, we want your comments.
I think very, very important discussion is going on. These are very important points for day to day. Everybody is doing too many angiographies, but these are very important points. So we must, while doing the procedure, we must follow these principles, and then we can get a proper angiogram, because that is the for that particular patient, that is the most important investigation. You cannot repeat the angiogram too frequently. And from angiogram, you have to find out, you have to take out all the information. So prior to angiogram, you have to take proper history, echo findings, then if required, all other investigations. And while going for angiogram, you must know what is the particular patient and what you want to see in that particular patient. If you are not able to see any specific artery or any particular totally occluded vessel, you have to find out from where you are getting collaterals or something like that. Always, while doing angiogram, you have to do the angiogram in such a way that if you want to plan angioplasty, your whole answer, your whole procedure should be planned on that angiogram. Or if you want to send the patient for surgery, then you have to answer each and everything to the surgeon. So very important topic today, and sir had covered each and everything, and there are very good comments from Hari Krishna sir and Dr. Milind. So my sincere thanks to everyone for this particular efforts to teach all the PG students, because this is the most basic topic and nobody talks on this particular topic. So my hats off to you, Dr. PK Goel sir.
Thank you, Ajay. So actually, this subject really belongs to my heart, because angiogram is something which I really love to play with. So, and my entire intervention, I can tell you, is based on angiogram. It is the angiographic interpretation. So I think this is very crucial. It's good if some people, students would have learned some points.
Absolutely. I mean, when students go into the cath lab, the first thing that they are taught is an angiogram, and people think it is very basic. So the immediate senior teaches them, and he rushes on to do the complex stuff. So
yes, that is
all too
that's
often.
what I said. This is something you take for granted. And if I tell you that learn angiogram interpretation, he will feel offended, that as if I am sort of degrading him. But he doesn't realize that is the basis. That is the founding stone which will make him a good interventionist.
I mean, such a kind of a talk or orientation should be given to every student on his first day in the cath lab. That is what I feel. And it should be repeated after a few days for the more senior students. It will be very beneficial.
Okay.
Sir, there are a few questions from the students. May I put to the question, sir?
Quickly.
Right, yes, now it's time. We need to leave actually. Chalo,
yes,
make it fast if it's okay.
Yes,
one or two questions only.
Yes, sir. So one question is regarding short LMCA, Dr. Vignesh. So he wants to know about short LMCA.
Short LMCA would be, it's a grade between double orifice left main, short LMCA, or separately arising LAD circumflex. So, these are all gradings of the same thing. You will apply the same principles as we just talked about the separate LAD and such.
Sure, sir. So the last question is, sir, what is wrapped up LAD?
What is wrapped up LAD? Now, this is that type 3 LAD. So this is the length. We were talking of the length of a vessel. So this is what it is. So if the vessel is long, it will supply a bigger area. So a wrapped up LAD actually wraps around the apex and goes into the posterior, into the typical type 3 LAD. But in that case, what will happen is that the RCA will, PDA from RCA will be shorter, because this is nature. You see, nature will not make RCA also as long and a wrapped up LAD also coming up. So if it's a wrapped up LAD, then the PDA has to be small. Actually, so this is based on this principle. I have made a computer-based system software which analyzes the vessels, gives it the myocardial value. It asks you two questions. One, tell me the syntax asks you dominance, RCA dominant, circumflex dominant. I explained to you that RCA dominant is not the last word. RCA dominant means PDA from RCA. It could be only PDA, it could be PDA and 1 PLV, it could be PDA and 2 PLVs, it could be PDA and super dominant, it could be any range, right? So I have designed a software where if he asks you a question, tell me RCA. RCA is PDA only. RCA is PDA plus 1 PLV. RCA is PDA plus 2 PLV. RCA is PDA plus more than 2, that is super dominant. So these 5 options he tells you. Or it is a non-dominant, means no PDA from RCA. Based on this, plus the second thing he asks you is, tell me whether it is a short LAD or an average LAD or this so-called wrapped up long LAD. So based on these two LAD and RCA structures, he makes the anatomical structure for all other vessels, right? So he will never allow you to score heavily for a circumflex which is existing with a super dominant RCA. He will never ever allow you to score. Supposing the PDA ostium has a stenosis, oh, bloody difficult, very big problem, and then can't do it, so we have to think for surgery or whatever. But if it is a super dominant RCA, he will reduce the value of the PDA. Mahajan, are you also listening? You getting the point what I'm saying?
Yes, yes.
Hari Krishna. Now, this is for the senior guys, not for the students. So it automatically will do that. And based on all this, so it will put you into a watertight compartment. Now, agreed that there is a circumflex with the superdominant RCA, there is a circumflex which has a lot of disease and problems are there, but it will not let you overload your system by saying it is the most complex lesion, and because it will reduce the myocardial value of that circumflex. As against syntax, which you tell him a OM, he will say OM. OM is OM. OM is 1. Finished. Or it is 0.5, whatever it is. But it will, here he will adjust that. And by that, the value that you will come out with, your value will have one, less variability between operators, and second, will be better predictive of whatever you want to predict out of the score. So
that is very important, sir, because the vessel is.
I was thinking I will, if some people are interested, I will do a what do you call it, Zoom session with some 3, 4, 5, 10 learned people, my senior guys, and try to make them understand what this system is. And then it could help, because this, I am competing with syntax. Syntax is world recognized. So I'm a small guy to compete with syntax.
I was interested in participating your study, sir.
So we'll make a Zoom session. I will have you in, so that you can at least see what is there in it. And
we'll
make your own
definitely like to
opinions, no
participate.
problem.
We like to participate, sir.
You can have your own opinions, no problem. Okay. So should we close now with this?
Yeah, I think.
I will request the Ajanta team to have the last word before we close. Thank you again to them.
Thank you.
Yeah.
Thanks a lot, sir. Mr. Sani?
Yeah, thanks a lot, Dr. Kamal sir and Dr. Phadke sir. So good evening to all the respected doctors. On behalf of Ajanta Pharma, I am Sunny Jaiswal, marketing head. Would like to take this opportunity to put formal word of thanks on record. Dr. Special thanks for making our today's 5th Cardio Master workshop a grand success. Would like to thanks to all our today's speaker, Dr. Professor PK Goel sir, for his insightful presentation. Special thanks to our course director, Dr. Ajay Mahajan sir and Dr. Milind Phadke sir for all the guidance. Would like to also acknowledge the contribution of today's expert panelists, Dr. Sandeep Bansal sir and Dr. H.S. Harikrishnan sir. Also would like to thank all the DM and DNB PG participants for investing the time in learning from the stalwarts of cardiology. We encourage all the participants for their active participation in all the future workshops too. With this, we conclude our today's 5th Cardio Master Workshop. Thanks to one and all. Good night and happy weekend ahead. Thank you.
Thank you. Good night. Namaste, everybody.
Good night.
Thank you very much, sir. Thank you very much.
Thank you, sir.